Thank you. I'm Dr. George Hruza. I'm a dermatologist specializing in skin cancer treatment, former president of Missouri State Medical Association, St. Louis Metropolitan Medical Society, and the American Academy of Dermatology, and adjunct professor of dermatology at St. Louis University School of Medicine. So thank you for allowing me to testify on these three bills. Actually, two bills, I understand. Sorry. So I'm testifying in opposition to those bills. I speak on behalf of the Missouri State Medical Association that represents thousands of physicians in Missouri in strong opposition to these bills. Patient safety of Missouri residents, your constituents, should be top of mind when considering changes to Missouri healthcare laws. Any proposed healthcare legislation should be assessed to whether it advances high-quality, affordable, accessible healthcare for Missouri residents. These bills earn an F on all counts. Malcolm Gladwell estimates that it takes 10,000 hours to become an expert in a discipline. How do nurse practitioners and physicians compare? Nurse practitioners have 2 to 3 years of post-college education versus 4 years for physicians. Nurse practitioners have no residencies but 500 to 720 hours of preceptorships, while physicians have 12,000 to 16,000, that's for dermatologists, of direct patient care through residencies and fellowships. That's in addition to the previous 2 years during medical school where they have clinical training as well. And even more concerning is that 60% of, as Dr. Thomas mentioned, of nurse practitioner programs are 100% virtual. And then they do the 500 hours of clinical training outside that. And we all know the disaster virtual education had on our K-12 students. So do you want to have someone who has been virtual training or learning to be able to work on you? Finally, physician training is multiple years of gradually increasing responsibility and independence with rigorous understanding of differential diagnosis in residencies accredited by the ACGB. APRN clinical training is through mostly observational preceptorships with variable quality control. In medicine, such preceptorships were replaced by residencies almost 100 years ago due to the inadequate training preceptorship offered for independent practice. The evidence in practice is also compelling. In my specialty of dermatology, nurse practitioners perform twice as many biopsies to find a skin cancer than a dermatologist. Nurse practitioners prescribe opioids to more patients than physicians, which is concerning at a time of the opioid crisis we are experiencing in Missouri. Really, we don't need to be prescribing more opioids. They order many more laboratory tests and imaging studies and prescribe more antibiotics than physicians. In the emergency room, patients treated by nurse practitioners without physician involvement have worse outcomes, especially for complex cases. This suggests that nurse practitioners are less certain of their clinical diagnosis, evaluation, and treatment plan than physicians. Also, what about consumer protections? Liability insurance has been mentioned and bandied about, but it's really about protecting the patient. Where are the deep pockets going to be? Affordabilities. These issues of actually some uncertainty leads to significantly higher costs due to unnecessary tests to the healthcare system and to patients, with many now having high deductible plans, so they have more out-of-pocket costs. Unnecessary tests also have negative consequences for patients. For example, unnecessary skin biopsies lead to more painful scars, risk of bleeding, and infection. Studies in hospitals, emergency rooms, and accountable care organizations have demonstrated that nurse practitioners operating without physician involvement give rise to significantly higher healthcare costs. So do nurse practitioners improve access to rural care? That is proposed as being useful, would be very helpful. Actually, they do not. Nurse practitioners practice in exactly the same geographic areas as physicians, desirable suburban locations. 9% of nurse practitioners practice in rural areas, and only 2% practice in federally qualified health centers. There is no causal link between independent practice and a mass migration of nurse practitioners to rural areas. This has not occurred in other states. And independent practice will not help to solve the access problem in underserved areas in Missouri. There are other ways to deal with it. So in conclusion, what do your constituents think about independent nurse practice? 95% of patients say it is important for a physician to be involved in their diagnosis and treatment. 3/4 would wait longer and pay more to be treated by a physician. 91% say a physician's education and training are vital for optimal care. Nurse practitioners are very valuable members of the healthcare team. I have several in my practice, and a physicians-led healthcare team is the high-quality, cost-effective care that our Missouri physicians deserve. Thank you so much. Did my 5 minutes, I think.
I'm sorry. I'll try to give you when you're getting short, and
Thank you.
I'm sorry. All right. Representative Fogel,
To inquire.
go ahead.
Thank you. Can you walk me through, in a typical collaborative practice agreement, and I don't know if this is defined by the agreement, by statute, by something else, but at what point do you, as a doctor, review the charts of your nurse practitioner who's working underneath you? Can you walk me through the timeline of that process?
So myself, I actually work with a physician assistant, and I review all their charts, every single one. Nurse practitioner I work with, I review every single chart. So I'm maybe an outlier, but I feel it is really important for me to be involved, because it is also my license on the line.
Of course.
When my nurse practitioner takes care of patients.
What is the requirement, though? Is it 2 weeks? Is it 30 days? I would imagine that's defined somewhere, that the doctor has to review the charts within a certain timeline. Do you know what that timeline is?
I do not.
Okay, because my question is, a lot of the concerns that you brought up are related to cost of healthcare, over ordering tests, and it just seems like a lot of the physicians I know maybe are reviewing those charts after the patient's already left, so they're already ordered whatever they were going to order anyway, so it doesn't really matter if the provider has a collaborative agreement or not, because they've already made the choice of what they're going to do in that visit. The provider is not holding their hand in the time that they're in the exam room. Is that fair to say, or would you say that's off base?
I would hope that a collaborative agreement is not just a piece of paper. It is a setting where the physician is available to the nurse practitioner, so that when she sees a patient that she has some questions, she's a little bit uncertain possibly, hasn't seen that before, she will contact her collaborating physician so that they can have a kind of curbside consult and address the issue. So that is how you would reduce the problem.
I want all of us to be aware that there are male in-piece mid-level providers, and they're female doctors. We're all, everyone in this room has used kind of gendered language. I want to point that out. So if someone, a subsequent testifier, could explain that to me, I want to understand what that process looks like, because I know, physicians oftentimes, or at least the physicians I know, aren't even looking at that chart until 2 weeks after the visit. And if that's the case, I just don't think that your concerns will change one way or the other based on whether or not there's a collaborative practice agreement. So I would just like to understand that for someone who's coming up next.
I totally agree. Thank you.
My second question, what was the statistic you listed about FQHCs? Because that seemed really low to me, that only
That 2% of nurse practitioners across the whole country. That is from the, I actually have a packet here of references that I have for everybody.
Okay, I would love to look at
review,
that. That
so you
number
can
just
review
seemed
those.
particularly low, just based on the FQHCs I know in Missouri. So if someone has any counter evidence, I would like to hear that as well. Thank you.
Questions? Representative Lewis,
Inquire.
go ahead.
Thank you. Good evening. Thank you for being here. I just had a question based on what the previous witness said and what you're saying with your collaborative practice. So I think I was very intrigued by the financial, to enter a collaboration that it can cost like 30 to 40K or something. So, and then also, I guess from your experience, you work with nurse practitioners. What is your financial agreement to collaborate with them?
Well, what we have in our practice is that the nurse practitioner gets a salary or percentage of productivity if they are billing under their name, and the supervising physician usually gets a monthly stipend not related to their productivity one way or the other. I believe in our practice it's about $2,000 a month.
Okay. And then is there a financial incentive for signing charts? You get additional money for chart reviews or?
No.
Thank you.
Further questions? Representative Seitz.
Yes, to inquire?
Go ahead.
Yes. I think you suggested that most nurse practitioners practice currently in a suburban setting. Do you think that it's because they practice in a more urban setting because of the restrictions that this bill is trying to alleviate? So really, if this bill passes and becomes law, wouldn't more nurse practitioners begin to practice in rural areas where there might not be the healthcare opportunities that we have in the larger cities?
That's certainly not been the experience of states where nurse practitioners gained independent practice. I do have an example of Oregon is a state which has been looked at, and it's going to be in this handout, which shows that physicians and nurse practitioners are exactly in the same locations before and after the law. So there's been no movement of nurse practitioners to rural areas because of the independent practice that they gained.
Okay, have you ever practiced in a rural setting?
I have not, but some of the physicians in my practice, I have a single specialty dermatology practice, do practice in a rural area in Illinois, in Mount Vernon.
Okay, thank you.
Representative Boggs.
To inquire.
Go ahead.
So I just want to get something straight in my mind, because from the document you read, it sounds like that there's a lot more oversight. But whenever I think about collaborating, I think about someone being at one location and someone else being at another location. So let's just say, for instance, you're the doctor, I'm the collaborator. I call you, I've got the patient there, and I'm telling you what I see. You're not seeing the patient, right?
Well, it depends on the setup you have. You certainly can nowadays. It's very easy to see
and
the patient.
I get that too. So yeah, that's maybe a piece and another question. But most of the time, if we're collaborating, you're making a decision based on what I present. Is that a correct assumption?
That would be and that's how it actually works when you're training in residency. You present, you're as a medical student or an intern, present to the higher up person the case.
Yeah.
And often that's actually done off-site as well.
So then there's a trust built in between. So that person is really not doing anything above, I hate to use pay grade, but what they're trained for. So you're not giving them permission to do something that they are not trained to do, correct? So if
Correct.
I collaborated with you and said, hey, I don't even know the situation, but say I've got training to here, you can't give me permission to do here, correct? I've still got my limitations. This law does not broaden my limitations, I guess is the way I should ask that question.
As far as what you can do, someone mentioned doing brain surgery, and certainly this law actually is silent on that. Just like the medical practice law is silent on that. I'm a physician and surgeon, and there is no restriction on what I do, so it will be the same for nurse practitioner. So it will be what they feel that they are able and ready to do. And there is nothing saying that they can or cannot do dermatology or obstetrics gynecology, because the law only says they're advanced nurse practitioner, and the scope is whatever their training is, and there is actually no restriction on it. So this removes any kind of checks and balances.
Okay, I think I'm confused.
Sorry.
Thank you, Chairman.
Sorry.
Questions? Representative Courtway.
To inquire.
Go ahead.
Thank you. Thank you for being here. Just a real quick question. In your practice, you said that you check all your charts of the nurse practitioner and the advanced physician. So what is your percentage basically each day or week of how much you actually get to see patients on your own if you're always basically checking over everyone else's work?
Well, so I do 40 hours a week of seeing patients, and I do skin cancer surgery. And at the end of the day, I review the charts. I review all the charts that I dealt with, and the nurse practitioners and the physician assistants chart that we have in the practice. It actually does not take a lot of time. The one benefit of some of these electronic records is that they're kind of formalized, very formalized, so you can very quickly get through to make sure that everything is okay.
So if you work your normal 40 hours doing your patients in surgery, then roughly what is your amount of hours you put in total per week then with that extra?
It's probably about 5 hours a week.
Okay, thank you.
Representative Keithley,
To inquire.
go ahead.
Thank you, Chair. Do you have any collaboration agreements or anything outside of anyone who's on location at your practice or your office?
So I myself do not, and our other physicians all have their collaborating agreements with nurse practitioners in their setting. So we do not have off-site, so like the 75-mile type of thing. We do not have any of that. We have everybody's on-site, and they are most of the time directly supervised, really, because there's a physician there at all times.
Okay, thank you.
Representative Hunziker.
Thank you, Mr. Chair. You were talking about reviewing charts and how you can do it fairly quickly. And what is the purpose of reviewing charts?
Is to make sure that we don't have any surprising outliers, because the dermatology is a very visual field, so we have pictures in there. So I will look at the picture and make sure that the diagnosis matches, and then also look at if they have a diagnosis, if the treatment matches. Also, we generally do not have nurse practitioners seeing patients as a new patient. You usually see them as established patients. So they already have an established diagnosis. We do not have them actually do the original diagnosis.
So you're making sure the treatment matches with the diagnosis that you gave them, the patient, is that right?
Originally, and of course there can be changes because it's an established patient. Sometimes new things come up.
Of course. And you review your own charts too.
Yes.
Is the review process the same for your chart as the nurse practitioner's chart?
Mine may be a little faster because I actually saw the patient, so I remember the patient, and so I can that goes faster.
So you look at it and say, "Yeah, I saw
yes,
the patient, and I put down what I thought
Yes,
was at the time."
Thank you.
Okay, thank you, Mr. Chair.
Representative Gregg,
Inquire?
go ahead.
Thank you. So you said you do have some APRNs
Correct.
on site.
Yes.
Okay. How many do you have?
Well, in my setting, I have one, and then in our other upstairs in the same building, we have one now, and then in our Illinois office, we have two, and we have another Illinois office. We will be getting another one, so we have a total of about 4 or 5, but different physicians are supervising those.
Sure. Okay. How often do you find errors in their recordings?
Fortunately, the ones that I have had that have been with me my physician assistant has been with me for 7 years, and I find those quite rarely.
In the beginning, did you find many?
But in the beginning, I find a lot more, and that's where in my mind the collaboration comes in when we discuss cases and talk about how we might want to handle them differently and what would be a good way to manage the case.
Okay. And you said you've got about how many? How much
I
time
don't-
do you spend checking over?
It's about 5 hours a week.
So 5 hours a week for the one that you've got?
Yes, for the one that I've got, yes.
Okay. Okay. Thank you.
Actually, I'm sorry, I misspoke. I have two because I also have I do now have actually a second one. So
And both
I'm
on
so
site
sorry.
then still?
Both on site, yeah.
Both on site.
So I apologize. I didn't want to.
Representative Seitz, is this your second time on this person or not?
Yes, as a chairman of tourism, I think that allows me to ask 2 questions.
I'm sorry, you're not the chairman of this committee.
Thank you, sir.
I give you permission, but again, in sake of time, and I abused that while ago, and I apologize, but in sake of time, make her quick.
Okay, thank you very much. All right, you inferred while speaking to Representative Boggs that APRNs would be able to treat possibly outside of their training. And I'm looking at the bill, it says, page 40, line 45, practice of advanced practice nursing, the performances for compensation of activities, services consistent with the required education, training, certification, demonstrated competencies, and experiences of an advanced practice registered nurse. So I'm seeing right here in the bill that I don't think they would be able to treat patients outside of their training. That would be part of the law should this bill pass.
So the reason I mentioned that there would be no more checks and balances is because the Board of Nursing determines the scope of practice for advanced practice nurses. And at least so far, they don't seem to find any restriction in their opinion. So that is why I was referring to that. So right now, you still have the physician that's involved in the care, so that to make sure that there's nothing that happens beyond where it should be.
Okay, thank you, Mr. Chair, for your indulgence, and I owe you one.
When I come to tourism, I'm one up. So, all right, Dr. Thomas, Representative Thomas, I'm sorry.
Brief inquiry, please.
Go ahead.
Thank you. I just wanted to thank you also for being here and to comment that it would make perfect sense that at this point, because you're in a collaborative practice arrangement, that you wouldn't be finding a lot of errors, because what you're reviewing in the chart, if I would understand correctly, would be if there had been questions about a particular diagnosis or an intervention or something that needed to be done, you've already worked with your collaborator, and that person probably would have been contacting you and working that out before the patient visit was over and before the documentation was done, so that one would expect that you have a good ebb and flow in your working relationship, and that ultimate documentation is the collaboration between you and your nurse practitioner, and there should be minimal errors at this point that shows the effectiveness of ongoing collaboration. Would that be a fair assessment?
Exactly, and every day I have my work with my. They call me over with a patient that actually comes within those 5 hours of my supervision. So I go over and they have a question about a patient, about something that they want help with, and we help her. With a physician assistant, it more often is because she helps me with closing, suturing up, and it's because she has a finger in the dike and there's some bleeder that she needs assistance with. So that to me is the collaboration part of it. It's that we work together, and the close collaboration, I think, is the key to optimal care.
Thank you.
Other questions? I have one real quick one. As former president of the Missouri Medical Association, what's the average cost to get through medical school, through medical school, not residency? Do you know that number?
It is north of $200,000 to do that. Now, that is at a private medical school. If you go to state school, might be less than half that.
Well,
Unless you go
a father, somebody's been through there. I wish we'd got through in $200,000 because that was fairly reason we didn't. We don't know what the average is.
Well, the average. So as I said, private schools are north of 200,000. And actually can go all 250, 260. Public schools are going to be in the 50 to 100,000 range, the much lower range in state schools tuition.
Talking about it 4 years or a year?
That's 4-year medical school. Now, of course, you have 4 years of college before then, too.
Right.
So that will add some more. Except if you go to my alma mater, which is New York University, which actually eliminated tuition for medical school a few years ago.
You're talking tuition only, not room, board,
Yes.
books. Okay.
And, of course, it was after I graduated, so I wasn't too happy. Sorry.
So could that amount of debt, what would that, if you're competing with that amount of debt for medical school, could that inhibit people from going? I'm a rural area. I'm in a medical desert. Some of you in this room know what I'm talking about, a real medical desert, Gloucester Hospital. Could that prevent physicians to going into areas because they can't compete with somebody who's a much cheaper education to go back. My fear, and this is a fear, is that we very well could be starving our communities of physicians because of the difference in debt of education.
I think that really applies especially to primary care specialties. Pediatrics is the lowest paid specialty. So it's not just the $250,000 of debt plus another 50 or 100 from college. It's also the extra years that you're going to commit to this, and the many hours and sleepless nights, including sleeping or not sleeping in the on-call room. So I know many physicians actually recommend to their children not to go into medicine and to go into physician assistant school or nurse practitioner, because it is also a well-paid specialty. You can take care of patients. You do provide good care, so it's very rewarding both financially and emotionally, or feeling a sense of purpose. So I do agree with you. I think that's a concern that it could certainly reduce that, especially for primary care, which is where the shortage is the greatest.
Well, I know as a veterinarian, return to capital employed, people don't go to rural areas because return to capital employed is not adequate. I don't know if that's the situation. I have a real fear that we could be completely starved and only be nurse practitioners in rural Missouri. Now, it may be anyway. That may be the fate we're going to see. But I have a fear looking at the debt load. Can they go back with that debt load and be competing with somebody doing the same things at a much lower cost of education? I don't know. I am toying with that idea. So, other questions? If not, thank you very much.
Thank you.